Hello, good afternoon, everyone. Thank you for joining. Sorry for the slight delay. We have speakers all over the place, all over the world, and a few technical problems. My name is Anya Sitharam, and I'm going to be moderating this session. My background is health and science journalism, and many years of making documentaries about global health. Today, we're going to be discussing the science of healthy living and how to challenge the status quo to enable healthier choices. So, what should policymakers do? What should governments do? And what should we as individual consumers do? To discuss, we have a panel of experts with us who are going to tell us about their latest research and also their work to help promote healthier living. We can't see, but in a minute we're going to be hearing from Professor Markus Peck Radosilovic, and he's Professor of Medicine and Chairman at the Department of Internal Medicine and Gastroenterology at Klinikum Klagenfurt in Austria. And he's also Chair of the Public Affairs Committee at UEG, and they're organizing today's session. We also have with us Professor Shira Zelber-Zaghi, who's the head of the School of Public Health at the University of Haifa in Israel. She works at the Tel Aviv Medical Center as a gastroenterologist. And then from the Netherlands, we have Monique van Leerdam, and she's Professor of Gastroenterology and Hepatology at the Netherlands Cancer Institute. From the World Health Organization in Geneva, we have Dr. Bente Mikkelsen. She's director at the Department of Non-Communicable Diseases, and her current focus is on achieving the SDGs through the reduction of premature deaths from Ncds, and a subject that, of course, is gaining prominence in the light of COVID-19. And from Brussels, we are joined by Emma Calvert, and she's the food policy officer from the European Consumer Organization, BEUC. And among the organization's aims is to enable consumers to make healthier choices and also to prevent vulnerable groups such as children being targeted by unhealthy food. But before we hear from our panelists, I'd like you to take part in a quick poll just to give us a sense of who is in the audience. And also, if you'll bear with me, I can't resist using a food analogy here, a taste of your opinion on some of the subjects we'll be discussing. It says how you can join the poll using a big marker. And the questions are, let me just show you the questions. The first one is, what is your area of work? So just choose one of those and click submit, and then we'll go on to the next question. What do you believe is fueling the obesity epidemic? And that's individual choices, advertising of unhealthy food, the convenience and accessibility of fast food, and high gym membership fees. You may choose more than one option there. And finally, let's go to our third poll. What is UEG's recommendation for salt intake? Is it 10 grams per day, less than 5 grams per day, or 5 grams per meal? So your choice is there. So first of all, Shira, what can you tell us about UEG?
So, hello everyone. First of all, thank you for the very nice invitation to speak in this distinguished forum. So, the UEG is a European medical association dealing with all aspects of gastrointestinal health. And I'm deliberately saying health and not disease because the UEG is not only interested in treating disease, it is also interested in dealing with other aspects of liver disease as prevention, as lifestyle-related aspects, and of course also quality of life of patients. For example, the activities of the UEG are very broad, and they have very active public health committee dealing with many issues important to patients, but also to the general population in terms of prevention of digestive diseases. For example, like food labeling policy statement that was recently published by the UEG. So we are really happy here to welcome you and to discuss hot topics related to digestive health.
Thank you, Shira. And I just can see the result of the polls now. So before we go to your presentation, I can tell everyone watching that the majority of people think that fast food and the convenient accessibility and convenience of unhealthy food is fueling the obesity epidemic. Nobody thought high gym membership fees, unsurprisingly, were a cause. A very small percentage thought that individual choices were responsible, and then some people thought that advertising, 24% thought that advertising of unhealthy food is a reason. Also, where you work, a couple from industry, so it'd be good to hear your questions and comments coming in our questions later on. And the majority are from academia. So thank you all for joining us. And finally, I'm sure you all know the correct answer to this. It looks like the majority, 96%, have decided that we should have less than 5 grams of salt per day. So I think with all these academics and people around and scientists, I'm sure that's the correct question. Is it the correct question, Shira? The correct answer? Yes.
Right?
Excellent.
One teaspoon.
So let's go on now to your presentation. And you're going to be talking about the synergies between risk factors and the impact on liver disease. Shira, over to you.
Thank you very much, Anya. So we usually look at risk factors for liver disease separately. And today I would like to introduce to you a different approach, combining all risk factors together and trying to understand the meaning of this combination, because in real life, everything is combined and not separate, as you know. So I'm going to focus on non-alcoholic fatty liver disease, shortly named NAFLD, and alcoholic liver disease. And it's amazing that these are two liver diseases with two separate etiologies, but in fact, they are twin etiologies. And if you look at liver histology, you can see that alcoholic and non-alcoholic liver disease actually look the same. And sometimes you can distinguish between the both. And they share very similar pathogenic mechanisms. So they both start with steatosis, which is liver fat, and then progress to inflammation in the liver, which can progress to fibrosis. Eventually, when the fibrosis gets worse, it goes to cirrhosis in certain patients, and even to liver cancer called hepatocellular carcinoma. And so we always try to separate the diseases. When we talk about non-alcoholic liver disease, we try to exclude consumption of alcohol. But in real life, I'm going to show you it's not always possible, that many people have both diseases altogether. And the shared behavior of bad nutrition and obesity, which are strongly related with non-alcoholic fatty liver disease, can often be seen also with people with alcohol overconsumption. So there is a synergy in terms of behavioral parameters, as I'm going to show you. And there's also synergism on the level of the severity of liver disease. The combination of both diseases together makes the situation worse for the patients. And then I'm going to discuss shortly the prevention measures, which are also, there is also a certain synergism between those aimed for non-alcoholic liver disease and obesity and those aimed for alcoholic liver disease. So non-alcoholic fatty liver disease is the most prevalent liver disease globally and also in Europe. In Europe, its prevalence is around 23%, and globally, the prevalence is around 25% of the general population. If we talk about the obese population, the prevalence is above 50%. In type 2 diabetes patients, the prevalence is around 80%. And you can see on the left that in different countries, the prevalence of NAFLD is determined mostly by the prevalence of obesity. And NAFLD is strongly associated with the metabolic syndrome, as dyslipidemia, hypertension, obesity or abdominal obesity, hyperglycemia, or type 2 diabetes. And in fact, NAFLD is considered as the hepatic manifestation of the metabolic syndrome. So I'm going to show you, this is an example why we can't always separate between alcoholic and non-alcoholic fatty liver disease. You can see here NAFLD patients and alcoholic liver disease patients on the black bars. And you can see that the prevalence of type 2 diabetes, hyperglycemia, and the metabolic syndrome is quite similar in the patients with alcoholic liver disease to the prevalence in those with non-alcoholic fatty liver disease. So we can't surely say that those who have alcohol abuse and have alcoholic liver disease actually do not have at the same time also non-alcoholic liver disease. And the non-alcoholic fatty liver disease, we now suggest to call it metabolic liver disease. Metabolic liver disease because it is strongly related with the metabolic syndrome. So patients can have alcoholic liver disease and metabolic liver disease. Another example in this large study of population-based study is we can see in the green and blue parts of, we can see that people with risky drinking or moderate drinking also have very high prevalence of metabolic syndrome. You can see that more than 50% of them have at least 3 components of the metabolic syndrome. So again, it's very difficult to separate the 2 etiologies for liver disease. So I'm going to show you now why is it bad to have both diseases all together as it leads to worse clinical outcome. And I will give you a couple of examples. So in this slide, you can see people divided by the presence of high abdominal obesity expressed with weight to hip circumference. And you can see in the lines, in the highest lines in both men and women, that those with the highest abdominal obesity, drinking alcohol leads to a much greater risk for severe liver disease than drinking alcohol leads to those without abdominal obesity. And if you look carefully, you see that even within the normal alcohol consumption of about 20 grams of alcohol per day, if a patient has obesity, then he has a much greater risk to have severe liver disease, whereas those without obesity can safely have moderate amount of alcohol of up to 20 grams per day. So there is a clear interaction between abdominal obesity and alcohol consumption, even within the normal range of alcohol consumption. And looking at liver disease mortality, you can see that those who drink at least 50 units of alcohol per week, which is above the recommended intake, if they are normal weight, they have 3-fold increased chance of having liver disease mortality. But if they are obese, they have 19-fold increased chance of having liver disease mortality. And even within the normal alcohol consumption of 1 to 14 units per week, you can see that if normal weight patients consume this amount, there is no increased risk for mortality. But if they are obese, they have 5-fold increased risk for mortality. And finally, there is an obvious interaction in terms of hepatocellular carcinoma. And you can see that people who drink and have BMI above 30 have 7-fold increased risk to develop hepatocellular carcinoma as compared to only 2-fold increased risk in those who are not obese. And what about NAFLD patients? If a patient had non-alcoholic fatty liver disease, is this okay for them to have a very moderate alcohol consumption of up to 2 drinks of alcohol per day? Well, apparently not. Also here, there is an interaction. So even if they drink a normal amount of alcohol per day, but they have non-alcoholic fatty liver disease, they have increased risk of fibrosis, inflammation, and increased risk of developing severe liver event. And those with advanced fibrosis due to NAFLD have increased risk to develop hepatocellular carcinoma, even if they consume only a very moderate amount of alcohol. And in terms of mortality in patients with NAFLD, interestingly, if we look at the risk factors for mortality in NAFLD patients, we can see that alcohol consumption is the greatest risk factor for mortality in these patients. If they have metabolic syndrome, then the risk for mortality combined with alcohol is much greater. And even binge drinking, meaning drinking of 5 drinks at once in one day, at least once a week, even binge drinking in NAFLD patients increases significantly the risk for mortality. So at the second level of synergy is behavioral. So we know that many people tend to eat unhealthy diets, junk food, become obese, drink soft drinks, and drink alcohol at the same time. And this is especially common in low socioeconomic parts of the society. And one example for that I can give you is a study in the United States looking at food insecurity. And they have shown that population with food insecurity, meaning with low socioeconomic status, have a much greater prevalence of NAFLD and a much greater prevalence of advanced fibrosis. And they say that low food security can explain it because there is affordability of high-dense, high-fat, high-sugar foods, and overall decline in dietary quality in low socioeconomic populations. And these are also the populations that tend to drink more alcohol. So that brings us to the diet quality issue. So what is a low-quality diet? Low-quality diet is defined as a diet that contains a lot of ultra-processed food and drinks, which is a major source of added sugar, saturated fat, and high-dense energy foods with low quality in terms of nutritional value, vitamins and minerals. And in fact, in several European countries, the percentage of ultra-processed food from the daily caloric intake is above 50% in both children and adults. So this is really something we should be worrying about. And it has been demonstrated in several studies that high consumption of ultra-processed food is related with increased risk of mortality, cancer, cardiovascular disease. And please look that the major sources, about 50% of the ultra-processed foods in this study from France comes from sugary and soft drinks. And specifically for NAFLD, there's an amazing study in almost 300 children with liver biopsy that shows that if children consume a lot of sugar in their diet, they have 60% greater risk of developing not only liver fat, but also liver inflammation. They have the more advanced form of non-alcoholic fatty liver disease. So not surprisingly, the American Academy of Pediatrics states that sugar and especially sugary drinks poses health threat to children and adolescents, disproportionately affecting children of minority and low-income communities. And obviously, preventable measures should be done and especially focus on low socioeconomic parts of the population and children. And to end with good news, if we take children who have liver fat and consume a lot of sugar and provide them with diet within just 8 weeks, a diet low in sugar, we get a very significant reduction in the amount of liver fat and the amount of ALT, which is the major liver enzyme. So short intervention studies reducing sugar can dramatically help the liver. And finally, the last level of synergism is in terms of policy, public health policies, which amazingly, the same public health policies that helps to reduce alcohol consumption also help to reduce sugar consumption and soft drinks consumption. So first of all, in terms of fiscal and policies and pricing, taxation and minimum unit pricing work both on alcohol consumption reduction and on sugar sweetened beverages reduction. And there is a lot of evidence globally and often from many countries in Europe putting taxation on soft drinks and alcohol and showing significant reduction in the consumption. Second, we need to change the environment. So we should limit marketing and advertising of both alcohol and soft drinks. And of course, use food labeling, but the nutritional labeling is not only for food and soft drinks, it is also for alcohol, because people need to know that, for example, alcohol contains a lot of calories. That might be helpful in reducing the consumption of alcohol. So limitation of marketing and food labeling. And finally, screening for population at risk. We need to find the population at risk from low socioeconomic parts of the society and other parts of different societies in Europe, and look for the patients who overconsume sugar and soft drinks and alcohol, sometimes in combination with one another, and try to create behavioral intervention programs, which also have been shown to be very efficient in reduction of both these risk factors for liver disease. So we need to join forces when we want to fight liver disease in Europe. These are the two leading causes of liver disease in Europe. obesity and alcohol consumption, if we join forces, we might be able to defeat both both major causes of liver disease. Thank you.
Thank you very much, Shira. And just to say to all of you, if you want to ask some questions, please submit them to the chat on the right-hand side in the Q&A, and we can put your questions after the presentation. Shira, interesting hypothesis there, and you advocate a strategy to tackle non-alcoholic fatty liver disease and fatty liver disease jointly. So what are the disadvantages of the current approach?
So the problem nowadays is that we look at the diseases separately. So first of all, the patients are unaware of the significance of the two diseases combined together, and they're unaware of the fact that it puts them in a much greater risk to develop end-stage liver disease, liver cancer, and this lack of awareness actually is not helping us in treating those patients. So first of all, we need awareness for the patients. Then we need awareness of the physicians. In primary care, then we need the physicians to be aware of the fact that the two diseases can exist all together. And we need better referral pathways. We need to treat these patients better in terms, for example, of a multidisciplinary approach. We need experts for alcoholic liver disease and non-alcoholic liver disease, and dietitians and experts in addiction, all to be working together and not separately. And in policymaking, I think that if these are the two leading causes of liver disease in Europe, we should work together, and maybe we'll have better achievements in terms of policy.
Well, that's quite a shake-up in terms of management of the disease, isn't it? It'd be quite difficult to achieve.
It is. It's a change of concept, but it's getting more and more acknowledged nowadays, and I think we are heading there because we are trying to separate two things that are inseparable.
Okay, and this is possibly quite a flippant question then, given the gravity of what you're talking about, but what do you think is more unhealthy, an alcoholic drink or a sugary drink, or both combined?
It's quite a difficult question. You would expect me to say alcohol, I think. But the damage of sugar-sweetened beverages is so evidence-based, and it's so commonly used by adults and especially by children, that I want to tell you that I think it's similarly harmful like alcohol consumption. Do you know that more than 25% of children and adolescents in Europe consume sugar-sweetened beverages, at least one on a daily basis? Can you imagine that? What would be in the next generations in terms of obesity and type 2 diabetes? We know that soft drink consumption, even one drink per day, dramatically increases the risk for developing obesity and type 2 diabetes, cardiovascular disease, and non-alcoholic fatty liver disease when they become adults or even in childhood. So it's not an easy question, in fact, and I really think that we should fight both. And we need to remember that also there are some alcoholic beverages combining both. Soft drink combined with alcohol. So this is really the worst.
Yes, and that's obviously used quite often to target young people, the sweeter alcoholic drinks. Thank you very much, Shira, for your presentation. Let's go over now to Monique van Leerdam, who's going to talk about the links between cancer and obesity.
Good afternoon. Thank you for the invitation. I would like to discuss about unhealthy nutrition and cancer. First of all, some cancer data. Already in 2015, the WHO published that cancer is the first cause of death before the age of 70 in Western Europe. And it's the second leading cause of death for cancer in Eastern Europe. So this is a major health problem for the young people. Worldwide, 18 million new cases and 9.6 million deaths cancer-related for the year of 2018. And we know that the 5 years prevalence is 43 million. So that means that 43 million people have had a diagnosis of cancer in the last 5 years. And they are still under close control or being treated for cancer. Europe accounts for 23% of global cancer cases and 20% of cancer deaths, with only 9% of global population. So cancer is a major problem in Europe. And we know that there is an increase in cancer burden due to population growth, the aging of the population, but also lifestyle changes. And these are mainly the Western lifestyle changes. So there is an urgent need for cancer prevention. So this is a figure from the 10 leading cancer types that are estimated for the year 2020 in the United States. So you can see for males, it's lung cancer, prostate cancer, and colorectal cancer. And for female, lung cancer, breast cancer, and colorectal cancer in the top 3. And the ones with the green arrow, those are the cancers that I do see in my outpatient clinic on a daily basis. So cancer is a major healthcare problem. There is a high cancer morbidity and there's a high premature mortality. So costs are really large, especially for cancer treatment, but also the economic burden is large for young people that are now not able to go to work anymore. So then what about prevention? Primary prevention or secondary prevention? I will first say something about secondary prevention. And I think that colorectal cancer is a really good example of secondary prevention. And you can see that in this graph here. In the dark blue bars is the uptake of colonoscopy in the United States. And already years ago, they started with a type of cancer screening and they offered colonoscopy. And you can see that with the uptake of colonoscopy, which is about 60% now, that over the years, the cancer incidence clearly decreased. This is the same as we expect for Europe, but waiting for these data because we started later with our cancer screening program. But we do expect a decrease in mortality through prevention and early diagnosis. Unfortunately, many cancers are not suitable for secondary prevention. So what about primary cancer? So they're attributable to modifiable risk factors. So what are then these risk factors? Well, of course, it's smoking. We all know the clear association between smoking and lung cancer. But it's also alcohol intake. It's excess body weight. It's red meat and processed meat intake. It's the low consumption of fruit and vegetables, the low dietary fiber intake, physical inactivity, the ultraviolet radiation by sunlight, and cancer-associated infections. And I will just go into detail in these 3 marked items. So first of all, excess body weight. Excess body weight is associated with 4.5% of all cancers developed in men and 11% of all cancers in women. And for women, it's especially in the uterus cancer patients, and its association between excess body weight and uterus cancer is in over 50% of patients seen. But also gallbladder cancer, liver, kidney, and esophageal cancer is associated with excess body weight. And we know, for example, in Rotterdam, it's the 2nd largest city in the Netherlands, that the adult population, 50% has a BMI over 25. And we also know that for children, there's a 10 times increase in obesity. And this is mainly because of the intake of the ultra-dense food, of the high-energy food intake, like the soft drinks, as has already been mentioned, and the fast food consumption. And obesity is still increasing. And this is a nice a picture from one of our UEG reports. And here you can see the energy-dense food, which is especially seen in sugary products. So if you want to decrease obesity, we should go for healthy food intake. So what about alcohol intake? This is the 3rd largest contributor to all cancer cases among women. It's about 6.4%, and it's 4th among men, which is 4.6%. We know that for oral cavity cancers and pharyngeal cancers, over 50% of patients do have a large alcohol intake. Also, esophageal cancer, breast cancer are associated with high alcohol intake. And then red and processed meat. This is more difficult. it is estimated that colorectal cancer in 6 to 10% and stomach cancer in 4% is associated with the intake of a high dose red and processed meat. There is a publication of IAC in 2015 where they evaluated more than 600 epidemiological studies, including 14 cohort studies, which are of the highest quality. And they found that there is limited evidence for the carcinogenesis of red meat and processed meat. There's also inadequate evidence in experimental animals. But there is supporting mechanistic evidence, and they conclude that probably red meat and processed meat are carcinogenic to humans. It's always difficult to find these evidence for less cancer with healthy diet is challenging. There are two examples here of studies. First is the Epidemic study. It's a European prospective investigation into cancer and nutrition trial among almost 500,000 adults. And there was a follow-up time of 8 years. And they could find a reduced cancer risk with high vegetable intake in women, but this reduction was very small. In another trial, it's a large prospective trial in Canada among 25,000 adults. They did find that co-consumption of low vegetables and food intake with a high processed meat intake was associated with a 2 times higher cancer incidence, but also with an accelerated time of cancer development. So in these prospective studies, it's difficult, and the problem is that there are residual confounders that are really difficult to exclude, confounders in our diet and in our lifestyle. So to get the evidence, we need to go into smart biomarkers or genome-wide association studies. They're going to start now, and they will probably give us the real data. So in conclusion, we have seen that secondary prevention, for example, colorectal cancer screening, is highly effective in reducing cancer incidence and probably also mortality. For primary prevention, there is knowledge about the potentially modifiable risk factors, and these should be used for setting priorities for cancer prevention and control. Up to 1/3 of all cancers are preventable simply by adherence to a healthy diet, maintaining a healthy weight, and regular physical activity. However, already in 2007, these recommendations were published by the World Cancer Research Fund, and still 13 years later, nothing has changed. So it's not easy to change it. And if we really want to change it, we should implement the known preventive measures, and we should do that on a European level or maybe on a national level. And we should convince the population, but also the policymakers. And as we have seen in the prior presentation, it's not only to prevent cancer, but it's also to prevent liver diseases. So I thank you for your attention.
Thank you very much. And we will be discussing what we can do to get those messages about healthy eating out later on in the discussion. But I just wanted to ask you, Monique, are there any particular groups which are more at higher risk from cancer because of unhealthy eating?
Yeah, I think it's a bit in the overlap for the presentation of Shira. We know that patients with a low socioeconomic status do eat more fast food because simply it's cheaper, and their physical activity is most of the time less, so they have risk factors. So more smoking, more fast food, more alcohol intake, and less physical activity. And buying vegetables, that's really expensive. So yes, the highest risk groups are in the low socioeconomic status group.
And you also talked about the association between a higher BMI and cancer, but can you actually say that a higher BMI or obesity causes cancer?
Well, it's like all epidemiological data. It's like the association between smoking and lung cancer. Those evidence becomes clear when you look at different groups and you look at the risk factors. And that's the same for obesity. And obesity is well is clearly associated to cancer incidence, but not to all cancers, but some cancers can be identified. And also here the problem is that there are confounding risk factors. Obese individuals more often do smoke, more often do take alcohol. So it's difficult to get one item exactly identified. But from all epidemiological data, we can say that it's really associated with cancer.
Thank you very much, Monique. Now let's go over to Dr. Bente Mikkelsen, who is at the World Health Organization and heads the Department for Non-Communicable Diseases. Bente.
Thank you. So what I will do today is to establish the very challenging fact that COVID-19 has been like an X-ray for all non-communicable diseases. So I will establish to all of you, which was also underscored by many of the other speakers here, the need to act. So I just want to start with this. It's a busy slide, but I'm sure that you know that we have 5 risk factors and 5 diseases. And since the discussion so far has been very much about obesity, of course, obesity is linked as a risk factor to heart diseases, diabetes, cancer, and also musculoskeletal diseases. So it is among the risk factors and underlying factors. And as you can see, even if we have a very high political commitment to fight all the non-communicable diseases, all of these diseases, so far we are not sort of really on track. We are actually off track. So only 17 out of 194 countries are about to reach the target of reducing premature mortality, meaning dying before 70 years of age for men for women before 2030, and only 15 countries for men. So we are already before the COVID in a very, very challenging situation. So the problem is, of course, so many of you know that the premature mortality is very high, and it is especially high in the lower and middle income countries. So this is one of the myths, that this is the diseases of the affluent. And since we are speaking about Europe today, many people think that this is the diseases of Europe. Actually, it is not. It's 3/4 of all those people dying before the year of 70 is in low and lower middle income countries. And to fight these diseases, we need to both do what we are speaking about today, namely focus on healthy living, but we also need to manage these diseases better. So what we have seen during COVID-19, and of course, all the governments of the world is now in the middle of defeating COVID-19. But what was coming through very clearly from both healthcare workers and from patients already, already in May, was that it was a deadly interplay between the COVID-19 and the non-communicable diseases. So if we looked at the people that were getting severely ill and actually also dying, these were the people with diabetes, with cancer, and with heart and lung diseases. So that was one finding. And the other one was, of course, that we saw that people had delays in diagnosis and also treatment. And it was a huge number of diseases that was untreated because of lack of access to healthcare. So you could say that people were unprotected. And unfortunately, we also saw examples that the food and beverage industry and tobacco industry utilize this moment to actually push unhealthy food and advocated for that for people. And it was also a lot of myths coming through. And we really had to focus even more to include healthy lifestyle in the protection during a pandemic. So the examples of this is, of course, as you can see, delayed care seeking, increased infection risk for people, diabetes patients that didn't get their insulin and also didn't get treatment for their complications. We also saw cancer prognosis and results of delayed diagnosis and also rehabilitation for lung diseases and other things very much disrupted. So we found disruption in more than 50% of the cases, and we also saw that people were suffering. So I don't want to give you a lot of figures, but if you focus on Italy, that was actually among the first countries in Europe that really were hit hard by the pandemic. You could see that 67% of those dying from COVID were living with hypertension and 31% were living with type 2 diabetes, just to make one example. So also the access to medicines were really a big problem in the low-income countries. 40% of them didn't have access to essential medicines. So what does this tell us? This tells us that we need really to build back better, and we need to include also care for people living with NCD and prevention for NCD in the national COVID plans. So we are, of course, now guiding countries to do so. But also, as you can see from this picture, we have the very big commitments politically. We have tools coming out of WHO. So, for example, to be able to fight the high intake of sugar, one of the really good buys is to increase the taxes on sugar-sweetened beverages. I'm sure we will discuss this later as well. So we have means to actually reduce and to reach the targets that was set by the Sustainable Development Goals of 30% reduction before 2030, if we really do this. So we need to learn from this pandemic, and we need to be sure that we are not coming into a new pandemic situation with the same fragility of the health system as we have seen today. So we also have seen that there are innovations coming around. So telemedicine, task shifting, a lot of things to learn from through this pandemic. So we have so far summarized that we have 10 really big learning points. And one of them, as you will see, is listening to people living with the diseases, and of course, to improve and increase and accelerate to do the policy options that and the tools that coming from WHO and partners. So I just put that picture as well, because we will be discussing this, I'm sure, today. And you see that we have all the risk factors among the policy options. So, for example, to improve physical activity, to reduce the harmful use of alcohol, tobacco, and also eliminate trans fat, and of course, be more clear on how to treat people with NCDs. We also need to learn how we can use regulatory measures in a better way. And we will have to learn from Mexico, who has already included increased taxation for sugar-sweetened beverages and have shown great results. And the same is also, of course, to focus on all the risk factors together. I will just mention one thing, just as, again, an underscore of the importance of really looking into both the political commitments, but also to the measure at hand. As you probably know, it is next year 100 years since insulin were discovered. And so far, only 50% of those in need of insulin has access. 100 years. So the question is, will we have the same difficult situation coming out in the next 10 or 15 years? And I will end up with this slide, and you can look at the right-hand side. This is the Director General of WHO, Dr. Tedros, and he says that we have witnessed 200 million deaths from non-communicable diseases among women and men aged 30 to 70 years during the last 20 years. We will see yet another 150 million premature deaths from NCD during the next 10 years, but we cannot see this development. So we can still turn the tide. We need to build back better and need to have all hands on deck and really fight the NCDs, and among these, of course, obesity. So thank you for listening to me.
Thank you very much, Bente. A question to you there, because you were very much talking about the impact of COVID-19. So what do you think we can learn from COVID-19 and the implementation of policies to prevent and also manage NCDs?
I think for the first time we have an X-ray, and the pandemic has sort of laid bare the fragility of the health system. So even if we have talked about it a lot, I think this time really governments see that non-communicable diseases, the heart and lung cancer and diabetes diseases, has to be part of the essential healthcare system. It has to be part of universal health coverage. So from sort of speaking about this, I think we now see the consequence of not actually implementing what we all have agreed on with the measures that we have. So that is the big learning point. So we cannot defeat a pandemic like COVID-19 without focusing on NCD if we want to save lives.
So do you think it's been a sort of wake-up call?
Absolutely a wake-up call, definitely.
Okay, thank you. Thank you very much to our speakers there. And we were really hoping to join Emma Calvert, but I fear she's not here. She was from the European Consumer Organization, BEUC. And also we saw Professor Peck tantalizingly there for a minute, but unfortunately he's disappeared. But we're going to have a lovely discussion now and ask the audience to start sending their questions in. Just before we go to our Q&A, I just thought we would have a little word cloud. So you can go to the Ysembly app and it will tell you how to do that. And I just want to have a little experiment to see if everybody, and including the panelists, could choose one word that you think encapsulates healthy living. So do go ahead. I think it'll tell us how to do it. There we are. It says to participate in the word cloud, please open appsysembly.com. So let's see if anything is coming up. Yes, there's one there, balance, about healthy living. And that's a nice, gentle word perhaps, but perhaps quite difficult for many people to achieve. Exercise, moderation, again, moderation and balance. And I think a lot of people, moderation is a difficult word, isn't it? Because one person's moderation could be another's excess. But yes, privilege. And that, of course, is a really important word, especially in the light of COVID, because that has really shown up a lot of health inequalities, and people to live healthily perhaps need to be privileged and have access to healthy food. Let's see what else has come up. Diet, transparency, that's interesting as well. Priority, cycle, nutrition. So I think there are balance, privilege, priority, and diet seem to be having most common votes. Incentives, mindfulness, and there's something there about mental health as well. Balance is seems to be the word, a balanced diet. Okay, this is interesting, isn't it? Let's go to each of the panelists while these are coming up. So Shira, is there a word there that stands out to you?
Well, I would go for balance. I'm not very original, I'm sorry. But what I mean is not balanced diet. I mean to balance between your needs and what you're willing to do and your quality of life. So it's always a negotiation between ourselves and between the physician or the dietitian. What are we willing to do for better health, but without harming too much the quality of life? So I think we need to balance between the patient's needs and the patient's values, and always to negotiate things with him to reach this balance. eventually when we make the treatment plan.
Okay. Would anyone else like to comment? Bente, did a word come out for you?
So I think I have to say it was a set of words that were really missing, because most of the words on the screen was for individuals. Well, I'm very much into protection. So how do we protect our populations? Because I mean, it's only so much you can do for healthy choices and true health literacy. It's actually up to the government to protect against, most of these very, very damaging risk factors, being it air pollution, being it alcohol, being it tobacco, but also unhealthy foods through regulatory measures. So I would choose protection, and I'm not playing by the rules, I understand, but I think from where I'm coming from, we need to really look into the public health measures. And in addition, we also need to look into the individual measures.
Right. Okay. Sort of much more public health focused approach there. And finally, Monique, did you have any reaction to the words chosen?
Yeah, I would go for the privilege and priority. I think privilege is indeed a problem. If the low socioeconomic status really depends on what you're eating and how much you know about physical activity and how easy it is to do or not to. I think as long as our healthy food is almost 3 times more expensive than our fast food, it's really difficult to make choices if you don't have the money for it. So priority is essential, a priority to make choices as a policymaker, to help those people so that they can make the right choice. But also priority in your advertisement. As long as we advertise about this fast food and about the sugary products, as we do it at the moment, then people really think it's okay and you can easily buy it and you want to buy it. So for me, it's privilege and priority.
Okay, thank you. And so the privilege is an interesting word there, and lots of questions coming in on the chat. So I will go to some of those at the moment, but I just wanted to reflect the whole idea of COVID-19 and the fact that it has shown this health inequality, and how are we meant to eat healthily? How are we going to expect people to eat healthily, given that healthy food is often very expensive and we have a huge economic downturn coming up and unemployment? How can we expect people to try and eat healthily and do all those things like exercise, etc.? I wonder, Bente, if you have an opinion on that.
Mm-hmm. So first of all, I think now coming back to Monique, and I agree. And then I think exactly that's why we need to do, also using the taxes, because this is a way to cost the negative externality. So the cost of, a very sweet drink is actually a huge cost for the society, even if it's a very cheap one for the consumer. So again, that is coming back to the public health measures. To your question, I think it's absolutely possible. I don't say it's easy, but that's also why WHO colleagues has issued, guidance for healthy living during COVID. So being physical active, trying to sort of reduce the temptation that many have by sort of eating more sugar. Also, of course, try to use the situation for banning tobacco, both for yourself and for your populations. So I think it's possible, and it requires an awareness, and also again, community level and government attention, especially during a pandemic like this.
Okay. Do other people think it's possible for people to eat healthily under these conditions?
Yeah, it is of course possible, but you need discipline indeed to do it. And with at the COVID time now, with more people working at home, a lockdown, not be able to go outside, or maybe not the urge to go outside, it makes it all more difficult. But I think it should come from ourselves, from the people and from the government probably. So yeah, we should do it. I think we can do it. That is not easy.
Absolutely. And finally, Shira, I mean, we say we can do it, but it is pretty hard for someone who doesn't, who's lost their job and probably wants to go and buy the cheapest food. And often the cheapest food is the highly processed, ultra processed food.
Absolutely, and there is increasing evidence showing that people during the pandemic tend to consume more junk food and, of course, exercise less. And there is some evidence for increased obesity even. So obviously it's a great challenge. But first of all, we need to tell the population that obesity increases the risk for having a more complicated COVID-19 disease with a greater risk of mechanical ventilation and mortality. It has increased risk of about 2 to 3-fold. And so they need to be aware of it, that if they want to stay healthy, even in times of epidemic, they should keep their general health better and not to gain weight. So first of all, knowledge. And then we need the governments and the policy to help us and subsidize fruits and vegetables and healthy foods, especially due to the economic crisis coming with COVID-19. And we know that healthy foods, as was said before, is more expensive food. So we need the help of the governments here to subsidize food and to make healthy food available. And we need to keep telling the public again and again and again that it is extremely important to their health, especially now. They need to keep their health, their weight to be normal weight. And if they have diabetes, they need to even treat it better to keep themselves healthy.
One of the questions that's come in is talking about the taxation of high sugar beverages, which was mentioned earlier. But do you think we should have more incentives than taxation? And, can you give me examples of nice incentives to promote healthy living? Monique, I think when we were speaking before, you were talking about cases where perhaps there have been pilots in the Netherlands where people have been introduced to healthy eating and healthy food, and it's really helped them.
A very nice intervention where they gave healthy lunches and extra time for physical activity on schools, on primary schools. So they did it on 3 primary schools, and they compared it with schools where they didn't change anything. And they had a follow-up time of 4 years now. The data are not published yet, so I can't show you the data. But they showed that BMI was decreased in the group that had a healthy lunch, and also their school performance improved. So they had more physical activity and a healthy lunch. So maybe by interventions like giving children already healthy lunches, but also maybe on large companies, provide healthy lunches, that may be a good intervention to reach the goal that we want, less obesity, also more knowledge about healthy foods, and then activity should come along. So I think that's a nice intervention.
That is nice, but I suppose right now, in the time of COVID, where a lot of people are working from home, they're not going into offices. Children are going into school, obviously, so they could be given healthy food. But for many people, they've got their fridge groaning with unhealthy things. How do we actually help people and get the message out there? I just wondered if you guys had any more thoughts on that.
Well, I think we are already struggling for this for years. It is really difficult, and I think it's not only in tax in giving tax to the sugar products, but it's also in providing a less expensive fresh food.
Yes, okay. Bente, you wanted to come in there.
No, I think as Monique says, the COVID has been sort of like an amplifier. So all the things we struggle with during COVID on healthy lifestyle is just even more challenging now and more important. So I think the combination of, the awareness raising and constant information and in working on the health literacy for families, for schools, for prisons, for whatever workplaces is very important. And as we have said during this discussion as well, that if you just look at obesity, I mean, just the pure fact that it influenced negatively, as we have heard today, the cancers, the cardiovascular diseases, and the diabetes. And still, there are lack of information to the general population on this. So I think it's really a call for action to continue, the advocacy, the awareness raising, the training, and in this sense, also the health literacy. So people understand how to make healthy choices. Of course, we have seen new industry coming up, like the sort of online service of food and so on. And I think one of the things we need to look into is that only a specific segment of food? Is it easier to get online, provision of the more unhealthy food? So I think it's a lot of things we need to go into and learn. And I agree that, taxation is not the only solution, but definitely to work with countries in the prospect of protecting people. And also, as many have said on this call, that it is a socio-economic divide between those, and this is before COVID, and it's even, worse now, between those who can afford the healthy food versus those who have the unhealthy food. So all of these things need to be focused on. We cannot focus only on one thing. And I would advocate for, the information that is on WHO's homepages. And I'm not biased at all. I really want to stress this because it is a lot of disinformation going around. I mean, at one point, we even some people thought it was healthy to smoke. Of course, immediately we were able to show that this was, of course, completely false. But I think this is important to stress. Where do you find the right information for these kind of things? So I'm not saying it is easy, and we have a lot of measures. We just have to understand that this has to be accelerated, and this is what COVID is telling us.
You mentioned smoking there, and a question that came in earlier on was about alcohol, and should we approach alcohol and processed foods, for instance, in the same way as we tackled the tobacco industry? Would it even be possible to do that? Who'd like to go
So from
first? Go on.
Yeah, so WHO side, of course, we have a very clear opinion on tobacco. Tobacco is of no nutritional value. It is really only a harmful product. So I think when we speak about food and the whole food system, we need to work with partners from the sort of the agricultural sector and through the whole chain until the consumer is reached. So it's very different way of doing this. And I think we need to nuance the different sort of measures. But we need to absolutely monitor and especially on the alcohol side, as I said, we have seen very unpleasant, I would say, activity and approaches during COVID where people are less protected, and this has to be really watched and followed up on.
Shira, given what you said about the links between alcohol and also non-alcoholic liver fatty disease and alcoholic liver fatty disease, what do you think? Do you think we should have a much tougher approach on the alcohol industry?
Well, I think first of all we need to acknowledge that in these really stressful times, people tend to drink more. So this time of the epidemic is really difficult in terms of nutrition. We are in stress, so we eat more sugar and also drink more alcohol. So it's really like a vicious cycle, and the economy goes down, so we can't afford healthy foods. So we should use everything we can. So should we go harder on the alcohol industry? Of course. It has been demonstrated in several countries, like in Canada, Finland, and Scotland, that if you put taxation on alcoholic beverages or a minimum price per unit of alcohol, it works and it helps to reduce the alcohol consumption, especially the cheap alcohol consumption consumed by people from the lower socioeconomic parts of the society. So obviously, it's one measure we can do. Also, I recommend not to bring enemies into the house. So if you can't resist the alcohol, if you can't resist the sugar sweetened beverages or the cakes or the cookies, especially in times like that when we spend more time at home, I think it would be the wisest thing to do would be not to put these things in the house. These are real enemies, and we call it in psychology stimulus control, meaning that you don't put things that you can't control under your nose. You don't bring them into your house and say, okay, I can resist it. No, it doesn't work like that. So it's true also for sugary foods and drinks, and also for alcohol. And I would like to add to that something that doesn't cost money, because we know people don't have money many times to buy healthy foods. But here is something for free. Have family meals. When you do home cooking, not processed food, just simple, basic home cooking, and the entire family sits and eats together, it's good for health and also good for mental health. So this is one thing that doesn't cost us.
Maybe easier said than done, Shira, not bringing in these temptations into the house and cooking. So where does it start?
Anya?
Yes?
Hi, sorry, Anya. This is Emma Calvert from Bayek. I'm calling in, unfortunately, from a call because I wasn't able to connect. But if there is any time left, I'd be very willing to do my presentation. Apologies to interrupt this very interesting discussion.
That's okay. Rather than do your presentation, would you like to join in this discussion, because your sort of expertise really is about marketing and advertising, and it would be interesting to hear your perspective. We've been talking very much about taxation. We've been talking about trying to encourage people to eat more healthily. But it's also been mentioned that advertising plays a key role, especially advertising for children's foods. And you also talked about, when we talked earlier, about digital marketing, which is now a real threat. Perhaps you could just elaborate a bit about that.
Sure. I think the moderators are happy to move my slides along, if it's okay with you for me to make the presentation. Yeah, and then I can address those topics at the end.
Okay.
Okay. So profound apologies for the delay in me entering the meeting, and thank you to the organisers for inviting Bayek. So Bayek, very quickly, we are the European Consumer Organisation, and we represent 44 different independent consumer organisations across Europe. Just to give a very quick overview of what the current situation is with marketing to children, we know that obesity is prevalent across Europe. We have 1 in 3 children which is either overweight or obese, and much more likely, therefore, to become overweight or obese adults. At the same time, the WHO recognises that there's unequivocal evidence that marketing of unhealthy foods is strongly linked to childhood obesity. That said, unfortunately, the advertised diet bears very little resemblance to the recommended diet. A recent study this month from our French member, Joisier, it found that 88% of food adverts for children were for foods which were high in fat, salt, and sugar. And that said, we also now have the food and advertising companies 2 steps ahead of regulators in this regard, and there are new marketing techniques such as advert games and social media are increasingly used. So we and our members, we decided to do a joint action on one particular marketing strategy, which is the use of cartoon characters. So brand mascots like Tony the Tiger, or licensed media characters like Disney's Frozen princesses. And what we found that they were very prevalent on foods which were high in fat, salt, and sugar. Only 1 of over 100 samples that we found was actually used for fruit or vegetable, which was canned sweet corn. The rest were for sugary breakfast cereals, chocolate biscuits, or dairy snacks. So why do food companies use cartoon characters? Well, the simple answer is that kids love them. They're a very powerful and persuasive marketing tool. And young children, they lack the cognitive ability to be able to distinguish between what is entertainment and what is advertising. And they love the sort of the fun, adventurous, friendly depictions that they see on the pack. And we know that studies have shown that these characters can influence children in terms of brand loyalty and awareness, which in turn means that they make their purchasing requests to their parents in the supermarket, and creates this phenomenon known as pester power, which is very powerful. If there are any parents listening, they will know. So whilst it's on the packaging, as we call it, the silent salesman, they're also integrated throughout marketing strategies. And if the organisers could play this short video, this is what is known as an advert game, where the advert is integrated into a game for children. And the brand mascot is therefore integrated into that game as well. So you have cumulative scores, multiple levels, and invitations to keep playing, which means that children often are exposed to that brand mascot for a much longer time than they would be, for example, when they're watching TV. Characters also often have their own personalised social media profiles. So this is the Honey Monster in the UK, who has Facebook, Instagram and Twitter, which we all know are very well used by young people. So where is action happening? In Chile, there's been some quite progressive action here. They've linked their front-of-pack nutritional labelling to advertising restrictions. So any product which is high in sugar has to have, or sugar, fat or salt, has to have a warning symbol on the front of pack, and if that product has, or if a product has a warning label, they are not allowed to use the brand character or a licensed media character on the package. Unfortunately, in the EU, we are a little bit behind at the races. What is preferred in most member states is self-regulatory regimes, which unfortunately usually have very weak nutritional criteria and no restrictions on packaging. So our demands in this area are to end reliance on self-regulatory measures for marketing to children and introduce more stringent regulation which really tackles the marketing mediums, so also to include the packaging, not just TV, but also the marketing techniques, including the cartoon characters. Thank you very much for your attention.
Thank you very much, Emma. And do you think that the regulations on labelling should be across the EU? I mean, how difficult would that be to implement?
Yes, this is actually a real hot topic at the moment in the EU because the European Commission have committed to coming forward with an EU-wide mandatory front-of-pack nutrition label. By the end of 2022, they should come out with their proposal. What we, from a consumer perspective, would like to see is this Nutriscore label, which grades products from A to E and with a corresponding colour scale. And basically what it does is it translates the nutritional information on the back to create a score on the front. And what it's been shown by many peer-reviewed independent research studies that this really helps consumers to make better decisions in the supermarket. It's very difficult for consumers to be able to discern whether a product really is healthy or healthier than another product. So this is a really useful tool to help consumers when they're making purchasing decisions. And I think it's actually quite important because... Go ahead.
No, go ahead. So there should be harmonised labelling because it is very confusing, isn't it?
Exactly. So at the moment in the EU, you can have a voluntary label, but you're not allowed to have a mandatory label, a national mandatory label, because that will have to be EU-wide. So we're really pushing this Nutriscore label because it really does help consumers to make better choices. There were real-life supermarket trials conducted in France which showed that not only did it help improve nutritional quality of shoppers' baskets, but it helped the most the people from lower socioeconomic groups, which is really important because they tend to be the most at risk of becoming overweight or obese.
Thank you, Emma. And I think one of our speakers, I think was it Shira, said that alcohol should actually say how many calories are in a drink, and that might actually dissuade a lot of people from drinking more than one glass.
Yeah,
Yes.
unfortunately, unfortunately in the EU, it's something that we tried to fight for over the past couple of years to make alcoholic beverages show the nutritional information, but also the list of ingredients. It's one of the only products which is exempted from having to do so. All other food and beverages have to, so it's a very strange situation that alcoholic beverages are able to, even though they can be very calorific. Unfortunately, however, the wine spirits lobby was very strong, and what we've ended up with is a self-regulatory regime. And we, in our experience, have not had very good experience with self-regulatory options. They tend to be piecemeal, and only products that want to do actually show this information, which means that the worst offenders get away with not showing calories.
Okay, thank you very much, Emma. Thanks for that. I'm going to go back to the panelists here with a couple of questions that have come in, so we can try and answer them. One of them is about completely different from the subjects we've been discussing, but I don't know if any of you could potentially answer. Do the panelists have a view on healthy living and neurodegenerative diseases? Is there any connection at all between eating unhealthily and some of the increasing neurodegenerative diseases? Does anyone know about that?
Well, can you hear me?
Yes. Don't know where the
Okay.
echo's coming from.
Okay. The association is, I don't know why you hear me like this, but the association is between cognitive decline and obesity and unhealthy eating, just like cardiovascular disease. So, and not smoking, keeping a normal weight, and having a healthy diet, like Mediterranean diet, might help in reducing the risk for cognitive decline.
Okay, thank you, Shira. I don't know if the echo's coming from you or somebody else, but anyway.
I'm sorry.
That's okay. I'm not sure if it's you anyway. And there was a question that actually came in for the WHO. So, Benti, it says, great work done by WHO. How can we convince governments to act on the WHO recommendations to build back better?
I think, the figures that we have, the data that we have is already, I think, I wouldn't call it compelling. It's more like alarming, So I think, and I have seen we have webinars with governments every month, and we have been discussing with them, and I can see that there is a totally renewed interest both to prevent and to manage NCD. So I think, it is like any other crisis. That crisis is very challenging, very horrible, but it also gives a possibility to refocus and to readjust what we do in countries. So I am actually pretty sort of optimistic that I have seen so much coming from countries requesting support, really very specific questions on how to close the gaps and so on. So I think we together with all levels of WHO partners, like, the Atomic Agency, the IAC, all of these that are very important for us to support our work, FIO, the Codex and so on, we will be able to do a better job. And as you remember from my first slides, we know what we can do. So, and of course we can refine, we can become even better. But if we just use the tools that we have already, the menu of policy options, we will be able to reduce the premature mortality with 25% and 30% before 2030.
And that is a very positive, possibly final words. I just have one question for the three of you before we close. And I suppose because we've been talking about food I want to imagine we are in a cookery show and come up with an analogy. So what 3 ingredients would you include if you were going to lead a healthy life? And you can use an actual ingredient, or you can do something slightly more metaphorically. So Monique, what 3 ingredients would you include?
Well, I really would like to include some lettuce. I would put on some tomato with it and some cucumber. Only 3. I really like fish, and I think that's is nice to add to it.
Okay, thank you very much, Shira.
Well,
Okay, we won't ask you. Sorry, Shira. Okay, Benti.
So I would say that we need to reduce some of the ingredients, reduce the risk factors, and listen to those who are going to eat the food. So, and then try to make some innovations, because we need people to be enthusiastic when they eat this meal. So, and also bring all the different cooks together so we can really have a great meal, all of us, on a basis of known ingredients. Thank you.
Thank you very much. And we're running out of time, and the questions are still coming in. They are really interesting, and I'd love to go on to talk about the different kinds of diets that there are: Atkins, paleo, etc. But we don't have time, so I would love to thank our panelists. Emma, who joined on the phone. Unfortunately, Marcus couldn't join us, but I just wanted to say that UEG has also recently published a position paper on front of pack labeling. Also, Bente Mikkelsen, Shira Zelbazagi, and Monique van der Leerden, thank you so much for your very thoughtful comments. And thank you all for watching, and enjoy the rest of the Gastein Health Forum. Thank you very much.